Hello, everyone. I am Francis Lee. I'm a tumor surgeon, orthopedic oncology at the Yale School of Medicine. It's so much pleasure to meet you on Zoom. And I work with Dr. Deshpande, Dr. Olino, Dr. Ledich, and we have a very strong team for connective tissue oncology, meaning sarcomas in the muscles and bone. At the same time, we provide all the metastases from lung, kidney, prostate, thyroid, melanoma to bone, including myeloma and lymphoma. It has been very exciting year over the past 10 years.
My pain is
And this is what we
really
do all
bad,
the time.
and I
This
cannot.
patient had a breast cancer, and the pain is unbearable after radiation, chemo, and the Prolia. Nothing worked. And you can see actually a femoral head seen through the pelvis. And these are the treatments we are doing now, 12 treatments. And most of them are open procedure. And we just stabilize the bone.
So
But from
my
oncological
pain
perspective,
it's
I do not think this is the really right treatment because we are not really addressing the radio or chemo-resistant cancers. And this is what we have been doing until 2016 nationwide, actually all over the world. We make a very big skin cut to expose the hip. This particular case is a thyroid papillary cancer, destroying the bone. And then we replace the hip using very big implants. But after radiation, patient can get infected and we cannot continue oncological care due to infection. I moved from Columbia University to Yale in 2016, and I was very fortunate to meet Dr. Ledich. And this is what I have been dreaming about over the past 20 years. And we have developed a minimally invasive procedure for all the skeletal metastases, just like for all percutaneous procedure for aneurysm and cardiac valve replacement surgery. Instead of making big incision, we are doing the same procedure through a very small, tiny incision. Dr. Ledich, can you join, or if you cannot join?
I am here. Unfortunately, I had a childcare issue, so I can only join by audio, but I can hear you.
Do you see any of my slides? Do you see?
Yes, I see all of your slides, correct.
Yeah. Can you add some of your statements? This is the movie you made.
Yes, this movie has a long backstory, and I will spare you from some of the juicier details because it might be in violation of some of our present-day tariffs. But this shows the procedure that Dr. Lee, in fact, dubbed AORIF, which is a modification of another well-known surgical acronym, where A stands for ablation, O stands for osteoplasty with a compliant balloon. Typically, R is reinforcement, typically cement reinforcement and internal fixation. So as you can see from the animation, this is all done percutaneously using a combination of fluoroscopy and cone beam CT. We are also able to do these with conventional CT in some cases, and we're looking to actually make this even more precise and probably even less minimally invasive, if that's even possible, by using navigation and hopefully robotics someday. So the approach is that using fluoroscopic guidance and basic anatomical landmarks, we make a tiny little incision just wide enough to be able to accommodate one of our guide wires, and then advance it using multiplane fluoroscopy into and through our lesion, target lesion, typically in this case, for example, in the acetabulum. We may place a few guide wires depending on the size and location of the lesion and its need for stabilization. Once we have the guide wire in place, essentially half the battle is complete. Now we have our access, and then over the guide wire, we placed a cannulated screw, a screw that has an open inner channel, obviously. And now through that channel, through that screw, we have a portal into the lesion. So through that channel, now we can perform an ablation, a thermal ablation. Typically, we do radio frequency, but one can perform any type of an ablative procedure one would like. Some places, some centers use cryoablation. There can be some challenges with cryoablation and injection of cement because they can obviously cryo create generous ice ball. It might be a little harder to inject cement. So we typically will use heat ablation. Once we are done with ablating, we remove our ablation probe and typically place the compliant balloons. And by the way, we initially borrowed much of this toolkit from the vertebroplasty or kyphoplasty set. So it's essentially much of the same tool. So with the balloon, we push away some of that scarred, destroyed tumor tissue to create a central cavity, because believe it or not, as many of you know, even with lytic lesions, there's still, it's not an empty space, obviously. It's not entirely a hole in the bone. There's still some matrix there, whether it's mucinous, fibrinous, something else. So once we have ablated, we push that tissue out of the way to create a central pocket that'll allow us to now inject bone cement to help with reinforcement. And now that once we have cement deposited, we drill the screws through it into their final resting position. Now we also have access to screws that have side holes along their length. So now we can actually advance the screws into their, let's say, final resting position before we inject cement. And once we inject cement, we usually within about 20 minutes of the time when we mix up the cement, within 20 minutes, that cement is rock solid and the construct is stable. We come out, close the tiny little incisions with sutures, staples, etc. Put little bandages on. Patient goes to recovery, and typically, most of the time, goes home the same night. So that's the long and short of the procedure. So I'll turn it over back to Dr. Lina.
Thank you so much. So this technique was developed at Yale, and the patient's actually flying in, and the patients goes home on the same day. So we are providing care for medical oncologists so that oncologists can give chemotherapy the next day without waiting 2 or 3 weeks. That used to be the case after open surgery. So we see patients in Trumbull, New Haven, and also Stanford, and we'll be glad to assist to your medical oncology care. So this is another example, 3-year breast cancer patients. Patient couldn't walk. This is a de novo diagnosis of stage 4. And we did our minimally invasive procedure. And she was able to ambulate the next day. And she sustained for 4 years. This is another case, same breast cancer patient. Patient is now 5 years out of the procedure. And nowadays, all of you made a miracle. Cancers are manageable disease, and we can facilitate your oncological care. So another patient with a renal cell cancer, you can see hypervascularity, and the patient can go home on the same day. This is the movie at the recovery room. So 3 or 4 hours later, the 1-hour procedure, the patient really walked home.
So the problem is my trophy can.
And this can be also very powerful for multiple lesions. Patient had a bilateral acetabular fractures, right femoral lesions, left femoral neck fracture, everything in one stage, and the patient went home on the same day. Patient also had a very radiation and the chemo refractory Paget's sarcoma with the spine and the left hip lesion. We were able to address both spine and hip under one anesthesia, and patient was able to ambulate right away. Another case of breast cancer after 5 years. The breast cancer relapsed, and unfortunately, the bone quality became very poor. We did the reconstruction, and the patient is still alive. So in summary, we will be very happy to provide a minimally invasive procedure for your effective oncology care without interruption. And I thank you so much for listening, and I'll stop here. And if there are any questions, Dr. Ledich and I can answer any questions. Thank you.
That's great, Francis. Really excellent demonstration of what you and Igor can do. So thank you for sharing those. I don't see anything in the chat right now, but if there are any, then I think Emily can send them to you. But in the meantime, while people are thinking of questions, I'll just move on to the next part of the slide of the talk. If I can figure out how to share my slide. Apologize. Technology is not my best friend. Can you see the slides now?
I can see them, yes.
Oh, great. So thank you, Dr. Ladich and Dr. Lee, for starting this seminar. And I'm also very proud to be a part of such a great team that involves also Dr. Alino as well, who should be hopefully joining us fairly soon. So we've heard about some of the newer surgical techniques from Dr. Lee and Dr. Ladich. I'll spend the rest of the time focusing on soft tissue and bone sarcomas. Now, the WHO has classified soft tissue and bone tumors into 4 different categories. Many of you will be familiar with benign lesions such as lipomas and malignant lesions, which include sarcomas. But there are also 2 other categories, and these include intermediate grade tumors that are rarely metastasizing, and I put one example as a giant cell tumor, and intermediate grade tumors that are locally aggressive. And these include something I'm going to spend a little more time on, which is desmoid tumors. The management of soft tissue and bone tumors in general is similar to many of the malignancies that we see in oncology. So the main treatment historically has been surgery. But these days, as just like you heard from Dr. Lee and Dr. Ladich, other techniques have been used because surgery can be very morbid or it might delay other treatments. So various ablative techniques similar to what you've just seen have been tried, as well as radiotherapy and medical management. And this includes chemotherapy, targeted therapy, and immunotherapy. So my first case is actually a case of a patient with a desmoid tumor. This is also known as an aggressive fibromatosis. It goes by many different names. This is a 39-year-old woman who in September last year noted a lump in the right axilla. The following month, she had an ultrasound which confirmed a mass and measured it at 6.9 by 3 by 5 centimeters. This was confirmed on an MRI scan, which suggested it was a little bit larger, 7.9 by 5.2 by 4.8 centimeters. And an ultrasound-guided biopsy showed pathological features consistent with a desmoid tumor. So I don't know if, Igor, if you're still able to talk, but I don't know if you can take us through this MRI picture.
Yes, I'm here. Okay. So we see this irregular. If you were looking at an X-ray, I suppose one could almost call it a spiculated lesion, which is fairly characteristic appearance for a lot of these uh, desmoids and aggressive fibromatosis. They're typically not very well circumscribed. They tend to kind of invaginate themselves through all sorts of tissue planes, which is what sometimes makes them a challenge to surgically resect, for instance. It's not always easy to get very clean margins because they're so irregular, jagged almost. And you can see this fairly typical appearance of it being very bright on this C2 sequence or contrast enhanced sequence. Either way, they tend to really light up quite obviously. And you can see them, the prongs of the lesion kind of thicken into various tissue planes in between muscles and tendons and fat planes. So this is precisely, like I said, what causes them to be a bit of a surgical dilemma, particularly in this area. Now, I can't see on this one sequence exactly how close the brachial plexus is, but in the axilla, that can always be a problem from a management standpoint, to try to peel away all these prongs of the lesion away. But this is pretty much the classical appearance of these lesions.
Great, thank you. And actually, it's exactly as you said. She first saw Dr. Alino, and she pretty much said word for word what you said. Because of its location near the brachial plexus, it would have made surgery very challenging to try and get all of this tumor out. So desmoid tumors are quite rare. They affect somewhere between 3 and 6 cases per million population every year. But, and this accounts for about 1,500 cases a year in this country. However, most patients do not die of their disease. So there are many, many more patients living with desmoid tumors. And this is why the prevalence is so much higher. The median age, it's a young person's disease. So we tend to see cancer in older populations, but desmoid tumors tend to have a median age of 20 to 44, but it is quite variable. I have seen patients who are much older, and we've also seen desmoid tumors in children. Most desmoid tumors are sporadic, but there are some that are associated, as many of you will know, with the FAP gene, or familial adenomatous polyposis gene. Desmoid tumors can occur anywhere in the body, as shown on this particular slide. There is a slight increase in incidence in the intra-abdominal or abdominal wall area, but their symptoms really depend on where the tumors are. As again, you can imagine, if there's a big mass somewhere, it's going to cause symptoms related to the size of the mass. So this can be trouble breathing if it's in the chest wall, abdominal distension if it's in the abdomen, and masses or restricted mobility if it's in the extremities. Over the last few decades, a lot of work has been done, however, into what causes desmoid tumors. And one of the first things that was realized is it seems to have an effect, be more prominent in patients who have hyperestrogenic states. And this can include recent pregnancies as well as women more than men. It actually led to one of the first medical treatments being tried as being tamoxifen, which is an estrogen receptor modifier that we use to treat breast cancer. It wasn't very successful, but we still very occasionally use that medication today. Similarly, some desmoid tumors occurred at the site of prior surgery or prior trauma, suggesting that it was that traumatic event that ended up causing the tumor. Most of us get our treatment guidelines from something called the NCCN, which is a national guideline for treating every cancer. And the treatment guidelines for desmoid tumors have changed extensively over the last few decades. What we suggest these days is if you have a patient with a desmoid tumor, they should be evaluated by a multidisciplinary team, such as the one we have here at Yale. This way we can decide whether we should go with the standard first-line treatment, which is actually surveillance, or whether they need any of our other techniques that have been mentioned in this talk. So as usual for any medical condition, we need to do a good history and physical. And this is really for patients who have just been diagnosed to see whether they need further workup for familial adenomatous polyposis. Because if they do have that condition, especially if they're very young, then they'll need much more intense screening for colorectal cancer, as shown on this particular slide. Otherwise, we need to do surveillance imaging to see whether the tumors are staying the same, whether they're growing, or whether they're even regressing. So because some of the tumors can regress, as shown on this particular slide, over a quarter, so 28%, that's why we tend to use surveillance as the first line of treatment. A further 30% will be stable. So if they're not bothering the patient, if it was, for instance, just picked up on another imaging technique, then we would still just do surveillance to just follow them and be ready to start treatment if needed. About 42%, however, will have progressive disease and probably symptomatic disease. For those patients in the past, we used to do surgery, but as Dr. Lalic mentioned, this can often be a very morbid procedure where patients will need a very, very big operation to remove a relatively small tumor. Over the past few years, Dr. Lalic and Dr. Lee have really pioneered the use of interventional techniques. And I know I've shared quite a few patients with Dr. Lalic, and the ablative techniques for desmoid tumors, I would say, are they similar to what you just described on the first few slides, or are there any big differences from how you would treat a desmoid tumor?
It's all thermal. It's all thermal ablation. However, like I mentioned, or unlike in the acetabulum, especially if we're looking to put in cement, I prefer to use ablation.
Okay, sorry, you were cutting out a little bit there. Maybe we can come back to you when you're in a better area. But otherwise, we do have new medical therapies, and the medical therapies. Sorry, go ahead, Igor.
You hear us? Or
I can hear you better now.
is the line choppy? Got it. I'm sorry. So typically, with desmoids, we use cryoablation rather than a heat ablation, and that is primarily because on CT, which is what we use for guidance, we can see our ablation zones very nicely. We see these so-called ice balls almost perfectly delineating the margins of the tumor. Whereas with heat ablation, typically, let's say with sarcomas, we would use microwave ablation for larger lesions. You do not see that margin on imaging, at least immediately. You can anticipate it, but you don't know exactly where it is. Whereas with cryo, you can see exactly the margin of the ice ball. So that's one of the advantages, and that's the preferred modality for desmoid.
That's great. And then I know you mentioned the brachial plexus was a concern for surgery. So how would you get around that with doing ablation, or would you refer them to me for medical therapy?
So our preferred option would be obviously do no harm or do least harm first. So one would certainly start with systemic therapy first, see how the patient responds. Plexopathy obviously will bring more. The systemic treatment plays out. If an ablation is still needed, one can still do staged treatments to maybe manage, let's say, 90% of the lesion if we can't get the entirety of it. But in many cases, we can do some of these advanced ablations using neuromonitoring at the same time, so we can tell in real time if we are causing any damage to the plexus and just kind of back off. But our preference would be to go with systemic treatment first to see if that perhaps manages to shrink the lesion or at least keep it at bay.
Great, thank you. And that brings us into the medical therapist. So there have been a few advances in the last few decades, and they have moved earlier in the treatment. So I would say now we tend to get most of our referrals from orthopedic surgeons who have seen these desmoid tumors. They know that there's medications available, and they'll send them for surveillance and possible medical treatment to me before they attempt any surgery. And we used to use radiation a lot for desmoid tumors. I would have to say, I don't think I've seen radiation being used for desmoid tumors in the last 5 years. It just has fallen out of favor. And the main reason for that is, as I mentioned earlier, these patients don't tend to die of their disease. It can be a very morbid disease. They can have a lot of pain, but they live for as long as if they didn't have the desmoid tumor, which means if you're giving radiation or even doing a lot of CAT scans, you're exposing the patient to potentially a treatment that may result in a second malignancy. And that's the last thing we want to do, is to take someone who has an intermediate tumor and then give them a more malignant tumor. So we have to be careful with our imaging techniques. We tend to use MRIs or ultrasounds to follow these patients rather than CAT scans. And we save radiation for patients who really have failed everything else. So one of the medical treatments that we have seen over the past few years is something called nirogacestat or Ogsiveo. And I can say it because I've had 5 years of practice saying it, but like most of our oncology medicines, they don't exactly roll off the tongue. But this is a medication that's called a gamma secretase inhibitor, and it inhibits some of the genetic changes that occur in desmoid tumors, either related to the FAP gene or the beta-catenin gene. That's one of the other genes that can be mutated in this disease. So when this new medication was developed and they realized it had a lot of activity in the very early trials, they decided to test it in what we call a phase 3 trial. So this is a trial where a new medication is tested against the standard of care. Now, the standard of care for desmoid tumors is actually surveillance. So it was tested in this study against placebo. They had to have patients had to have a desmoid tumor that was histologically confirmed. They had to be progressing after 1 line of therapy or refractory to more than 1 line of therapy, and if they would have felt that if continued progression, they would have an immediate significant they wouldn't have an immediate significant risk if they had to wait if they were on the placebo arm. They did need biopsy to confirm the disease so that everyone had the same disease going into the trial. And they had to have what we call a good performance status, which means they were able to do all of their activities without being in bed most of the day or in hospital or anything like that. They also had to have adequate organ and bone marrow function. These medications, remember, had only been tested on a few patients before being tested in this big clinical trial. So we didn't know how it would affect patients in terms of side effects or in terms of some of their blood tests. The primary endpoint was progression-free survival. How long did it keep the disease as it was, or even keep it at a smaller size. And the secondary response rates included objective response, so how small could it make the cancer get or the tumor get, and also patient-reported outcomes. So if they had a lot of pain to start off with, did this medication make them feel overall better despite any side effects? So patients were randomly assigned to receive this medication, nirogacestat, 150 milligrams twice a day, or a placebo, a similar appearing placebo twice a day. If they did well on the medication, they were able to continue it. If they got the placebo but progressed, they were able to cross over to get this new medication. All patients had their tumors measured using a standard radiological technique called RECIST, and they had patient-reported outcomes very accurately measured, as well as looking at the safety of the medication. In this study, as you can see, the majority of patients had disease that was outside the abdomen, unlike that particular slide that I'd mentioned before for the general population. Patients either had single sites of disease or they were multifocal disease. The size of these tumors was quite large. So in the treatment arm, it was 9.1 centimeters, and in the placebo arm, it was 11 centimeters. A minority of patients, less than 20%, had familial adenomatous polyposis, and these were the genes that were mutated. And you can see here the APC gene and the beta-catenin genes. Some patients had no identified mutations. Many patients had already had quite a few treatments, in some cases up to 14 lines of prior treatment. And these are some of the treatments that they received. A vast, a significant minority, I should say, of patients had significant pain at the time of enrollment in this particular trial. We were one of the sites for this trial, and it was very exciting being on a medication that could be given to a disease that previously had no FDA-approved treatment. And you can see that there was a significant difference in progression-free survival on this particular graph. There's a wide separation of the curves between placebo and the study medication. And this is a graph that we use a lot in oncology called a waterfall plot. Basically, where you see the 0 line, that's the size of the tumor of each individual patient. Each bar is an individual patient. Anything that's going above the line means the tumors are growing, and anything below the line means the tumors are responding to treatment. And you can see on this first graph, the majority of patients, the tumors are getting smaller, and this dotted line is a 30% smaller line, and that's our arbitrary definition of a partial response. So over 40 or almost 40% of patients had at least a partial response, and some of them even had a complete response. That's where, when we do a follow-up scan, there's no evidence of disease on that scan. So this was really exciting stuff for a desmoid tumor. For the placebo group, again, some patients will have regression of disease without any treatment, and you can see that here. And others had progression of disease. And as I said, they were allowed to cross over and join the nirogacestat group. So for non-malignant soft tissue tumors, which desmoid tumor is one of them, they can either be totally benign, like lipomas, or intermediate tumors, such as desmoid and giant cell tumors. Usually survival is not affected by these particular types of tumors. So you have to be very careful about the treatments you give. You don't want to give chemotherapies or radiation necessarily, which might have a risk of secondary complications down the line, as these patients can live for many years. Similarly, when you're doing surveillance, you should opt for imaging techniques such as ultrasound or MRI rather than CT scans. But there are newer medications, one of which I've mentioned, Ogsiveo or nirogacestat, and newer techniques available for more advanced symptomatic cases. So that's the benign and intermediate grade. And I'm going to finally use the last part of the talk to go over sarcomas, which are malignant tumors. Sarcomas can be divided into two groups. They're either bone sarcomas, which you've seen some pictures on Dr. Lee's slides, or soft tissue sarcomas. And the soft tissue sarcomas are the vast majority, so 80% of all sarcomas. There are over 50 subtypes of sarcomas, and this is why it's often very difficult for physicians, even for our oncology fellows, to really learn about these diseases, just because there's so many of them and they're quite rare. So we see about 17,000 new sarcomas a year in the whole country, whereas we see 300,000 new breast cancers a year. So it's, unless you're dealing with these patients every day like the four of us do, then it's hard to really understand the nuances of diagnosis and treatment. Once again, though, for sarcomas, surgery is the mainstay of treatment, but it can be augmented with the use of radiation for soft tissue sarcomas and chemotherapy for bone sarcomas. Bone sarcomas tend not to be sensitive to radiation. There is a role for chemotherapy also after surgery in very large, high-grade sarcomas. So it's something you should think about for the more aggressive lesions. And for metastatic cases and some large tumors, we would think about giving targeted therapy or immunotherapy. So I'm going to continue with another slide. Hopefully, Dr. Alino will be able to join with some comments. This was a patient, again, I shared with her. This is a 69-year-old man who back in August last year presented to his primary physician with a 2-week history of bilateral lower extremity edema on the right as opposed to the left. At the same time, he had an ultrasound. The primary physician quite rightly was worried about a DVT, but the ultrasound didn't show a DVT. But very astutely, the primary care physician followed this up with a CAT scan of the abdomen and pelvis. And this showed a very large mass. You can see it's 17.3 by 19.1 by 23 centimeters, retroperitoneal, so in the abdomen, with extremely heterogeneous internal components. Now, this is a sign of a very rapidly growing tumor when it doesn't look the same all the way through. Sometimes we'll see these sarcomas that patients present to us with a huge tumor, but when you ask them, they'll say, oh yes, I've had this mass, it's been growing a little bit over the past 20 years, and it actually is a much more low-grade, often a liposarcoma. In his case, however, he had obstruction of the right ureter with right hydronephrosis, and an ultrasound-guided biopsy of the retroperitoneal mass was performed. The pathology was initially read as undifferentiated sarcoma, but now we have better techniques in pathology to actually place it in one of those individual 50 categories. And if they have this gene called MDM2 with certain other features, then we call it a dedifferentiated liposarcoma. So this is some of his imaging. And again, I don't see Kelly on the line, so I will do my best in my non-radiology technique to say, well, this is pretty obvious. This is a very large mass. And this is what they mean by the heterogeneous appearance in the abdomen. So areas that are lighter and areas that are darker. These darker areas probably represent necrosis. And if you see a lot of necrosis on a sarcoma specimen, then that immediately pushes its grade up. We use necrosis, mitosis, and the type of sarcoma to determine the grade of the lesion. And when staging cancers, many of you will have heard of the TNM staging system, where T is the size of the tumor and N is nodes, M is metastasis. But sarcomas have a fourth component, which is the grade. And it's so important that a tumor that's very small yet has a very high grade can be a stage 3, whereas if this was a low grade tumor, it would actually still only be a stage 1. So that's how important grade is, because it has such a key effect on the prognosis. So he underwent resection of the retroperitoneal tumor en bloc with the right adrenal gland, the kidney, the IVC, the common iliac artery and vein, and reconstruction with vascular surgery. It was a huge operation. I'm so glad Dr. Alino was there to do it, because she's used to doing these big operations. He needed 31 units of pat red blood cells, 19 units of FFP, 3 units of cryo, and 2 packs of platelets. And it involved 3 different surgical teams. And luckily, he did so well that he had an uneventful recovery. He was able to get home for the holidays, but unfortunately ended up with recurrent disease, including lung and retroperitoneal metastases. And I'm currently treating him for the metastatic disease. He technically would have been eligible for one of our clinical trials, however. And this is the schema for the trial. Basically, what we know with these very large retroperitoneal sarcomas is that surgery is a good treatment for them when they're very small, but the larger they get, the more likely they are to come back. So historically, adding chemotherapy or radiation to these tumors has not made much of a difference in terms of survival. In fact, radiation was tested in a very similar trial called the STRASS-1 trial, where just like here, patients were randomized to either get surgery alone or radiation followed by surgery. And this was a negative trial, the previous trial, the STRASS-1 trial. It ended up saying that radiation did not improve survival. In fact, in some cases, it was even detrimental to get radiation plus surgery. There were a couple of histologies, however, where it seemed like there may be a trend towards radiation being beneficial. But during that time, the chemotherapies that we were using and the supportive care that we were using has improved significantly, so that they decided to look at this question again. If we give chemotherapy up front, followed by surgery, is it any better than surgery alone? And this was started a few years ago, just before COVID, unfortunately, and then the study really didn't accrue very well. But now we're part of that particular study. So if you have any patients who have these retroperitoneal masses, definitely send them to the surgeon, but also send them to medical oncology to see if they would be eligible for this trial. And this trial is open at all of our network sites. In other words, you can refer them to a local oncologist and they can get their treatment there. Basically, they will get 3 cycles of treatment depending on what histology they have. If they have liposarcoma, they get one particular regimen. And if they have leiomyosarcoma, they get a different regimen and then go on to surgery. So a very simple trial, but a very much needed trial to see if we can improve on the treatment of these patients. Dr. Alino has really been working extensively with immunotherapy in her lab and her patients. And you can see she's mentioned that there are many different types of soft tissue sarcoma, as shown in this particular slide. And some of them can affect the immune system more than others. I'm not going to go too much on this complicated slide. So she treated a 77-year-old, very fit gentleman found with a left adrenal mass, resected and found to be a different kind of sarcoma from the one I just mentioned. This is an undifferentiated pleomorphic sarcoma. It recurred in 2019, and he underwent a partial colectomy and partial left nephrectomy. It recurred again in 2020, and he had completion of left nephrectomy and resection of the mass. And it recurred following that in 2022. And what they did was they tested his tumor at that time, and they found he had a very high score of PD-L1. This is one of the markers that we use in other cancers to predict for response to immunotherapy. Now, we know that certain sarcoma types respond to immunotherapy better than other sarcoma types. And this is a slide of all the different patients with sarcoma who have been treated with immunotherapy. And you can see the UPS, this is not the postal company, but this is undifferentiated pleomorphic sarcoma, often can have a very good response to immunotherapy, probably because they have a lot of heterogeneity, and this is a key for many cancers to respond to these immune treatments. So in 2022, he was treated with 7 cycles of pembrolizumab. Unfortunately, he had autoimmune hepatitis, and any time, as you've probably all seen in your practice, you have a patient who has an immune-related side effect, the first thing to do, if it's very severe, is to give steroids. This will very quickly, in the vast majority of cases, reverse the side effect. But it does mean that you can't restart the immunotherapy until they've tapered their steroid down to the equivalent of 10 milligrams of prednisone a day. In 2024, he was unable to restart the immunotherapy, but he had still fairly stable disease, probably because of the immunotherapy that he's had all that time before. And he started pazopanib, which is what we call a targeted therapy. It goes after, it's a tyrosine kinase inhibitor that goes after some of the enzymes that we think will promote cancer growth. Again, I won't spend too much time on this slide that Dr. Alino put together, but you can see there are many ongoing clinical trials that we use now, or that are being used now, for immunotherapy. We just closed one that we had here, but we will have others that will open either in our sarcoma group or in what we call our phase 1 early trials group. So I'm actually going to end the talk there. I don't know, Dr. Ladich or Dr. Lee, if you have any closing comments.
I'm still here. I think Dr. Lee had to leave.
Okay.
I think this has been a whirlwind tour, and I think there's nothing else that I can add that would make this any more glorious than it has been.
Thanks, Igor. And if any of you want to refer a patient, then feel free to contact us. We're all on the Yale email and in Epic as well. I'll just see if there are any questions at this time. I don't see any. So Emily, are you still on the line? Or?